Okay, everyone, welcome to our lecture on spirituality. This is intended to accompany the culture lecture, so for this week, be sure that you take a look at both. And as we go through, I think that you'll find that many of the objectives and concepts are very similar because both spirituality and culture are integral into the provision of whole person care. So when we are talking about things like culture, we're really talking about group norms and concepts. And when we're talking about spirituality, we're looking more at the internal and individual concepts. So here are our objectives. First and foremost, we want to understand the nurse practitioner's role in the provision of spiritual care. We will talk a little bit how spiritual systems define health, but in a more general sense. Certainly, discussing each individual religion and spiritual belief system as it pertains to health would be exhausting and probably not very helpful to you. So I encourage you all to get into your work environments, get a sense of what spiritual and religious belief systems you encounter frequently, and take some time to really learn more about any specific beliefs or rituals or things that are important regarding caring for patients, particularly if you are involved in those with life-limiting illness or at the end of life. We're going to talk about spiritual factors that affect patients and families' attitudes towards health maintenance, and also about how your own spiritual beliefs can influence attitudes and beliefs towards health maintenance. And certainly, because this is your health maintenance class and health promotion class, the objectives are geared towards that population. But I think as nurses, you probably have all had the experience in which you have seen how spiritual issues often come to the forefront for those who are acutely ill or dealing with life-limiting or terminal illness. So, of course, all of these principles should be applied in that context as well. So what is spirituality? I want you all to come away with the understanding that spirituality and religion are not the same thing, though they are often very intertwined. When we're talking about religion, we are talking about the community or group focus. A lot of the principles that we talked about in culture really more appropriately fit with religion than spirituality. So again, community and group focus. Religion is considered organized in terms of very defined constructs and doctrines, which is listed a little bit below. Religion is something that we often see as external and observable. We can watch specific religious rites. We can see that a person is wearing a cross or other signs of their religious identity. And formal rituals, ceremonies, and traditions are all intertwined with religion. Spirituality, on the other hand, is very focused on the individual. It involves a sense of transcendentness and connectedness to something higher than ourselves, whether a person identifies that as God or some other higher power. It is very internalized. You can't tell a person's spiritual feelings just by taking a look at them, and it's very highly personal for most individuals. So certainly you may find individuals in which spirituality and religion are so connected that it's difficult to distinguish between the two. But I want you to also understand that just because an individual does not identify with a specific formal religion, that does not mean that spirituality is not important to them or that they cannot suffer from spiritual distress. Conversely, just because a person identifies with a specific religion, that doesn't mean that their spiritual needs are automatically taken care of and that we don't have to delve into their spirituality any further. Related constructs which you will see written about in the literature and which I'm sure that you have encountered to some degree in your practice include things like hope, meaning, purpose, forgiveness, and a sense of isolation. So how can religion and spirituality impact health? And for the purpose of this slide, I have lumped them together because certainly there are a number of religious beliefs or doctrines that directly impact a person's healthcare decision making. So first, a little bit about health beliefs. Certainly religion and spirituality might impact how a person views illness, what they may believe can cause illness or causes a person to be well. Treatment choices come along these same lines, and certainly I think you've all heard of how certain religious practices or spiritual practices can impact choice of treatment, and you've probably read about specific examples in the lay media. Probably most commonly you will encounter a person who ascribes to Jehovah's Witness doctrine and will not consent to blood transfusion, and that's just one example. Goals of care is intimately intertwined with a person's spiritual beliefs, and I would argue that goals of care cannot even be addressed unless one first understands where a person and their family are coming from spiritually. And finally, end-of-life wishes, when one is dealing with people with terminal or very life-limiting illnesses, that's often when spirituality comes to the forefront. And actually, spiritual needs and interventions may supersede those that involve the physical health of a person. A little bit about spiritual and existential distress. In my mind, spiritual distress is just like any other diagnosis that you might encounter with a patient, such as dyspnea or chronic pain. And spiritual and existential distress manifest as feelings of abandonment or a sense of betrayal, feelings of fear or the desire to seek forgiveness, feelings of remorse, anger, hopelessness or despair, guilt or regret, and may fall along the same lines as actual clinical depression. And if there's one point to take away about spiritual and existential distress, is that if you encounter an individual who is suffering from pain or a symptom burden that is out of proportion to their disease process or is unresponsive to conventional interventions, one must consider that these symptoms are stemming from spiritual or existential distress and initiate the proper evaluation and interventions for that. So in our objectives, we mentioned that before one can care for another person or family from a spiritual perspective, you must understand where you're coming from yourself, and that's our spiritual self-assessment. So the tool that I'm going to highlight here is called the FICA tool, which we're going to go through step by step, but certainly, any other form of self-assessment can be appropriate if you prefer. So the F in FICA stands for faith and belief. Ask yourself, do you have a spiritual belief that helps you cope with stress or illness, and what gives your life meaning? The I talks about the importance of your faith and belief to you. So how important is your spiritual system and beliefs to you? Does it influence how you think about health and illness or your healthcare decisions? The C is where we get to the religious and cultural aspect of spirituality, and it talks about community. Do you belong to a spiritual community? And if so, are you happy there? Are you as involved with that community as you want to be? Do you need to search for another community? Or if you don't have a spiritual community, do you think it would be helpful if you found one? And finally, the A, if you look at different resources, the A may stand for slightly different words, but essentially it's what are you going to do about any deficits or concerns you've identified in your assessment. So here the A stands for addressing spiritual needs. So what is your action plan? Do you need to make some changes? And if so, what are they? Do you want to practice or do you want to initiate or expand on any spiritual practices? Do you think it would be helpful for you to seek formal spiritual support with a chaplain or a pastoral counselor, for example? So now that you've gotten a sense of where you're coming from yourself spiritually, then you can initiate a practice of assessing your patients and their families. And the first thing that I'm highlighting here with this flashing text that might end up giving you a seizure is that a spiritual assessment is more than checking a form on a box saying, what is your religion and would you like to see a chaplain? And I think traditionally that has been the extent to which a spiritual assessment has occurred, either in the in or the outpatient setting. I don't want you to worry that a spiritual assessment is going to be too time consuming, because I know we're all busy dealing with a myriad of issues in order to provide our whole person care. But something as simple as asking an individual what gives you meaning or hope or purpose can really give you a sense of where they're coming from spiritually. A question that I would frequently ask in my palliative practice is, what is most important to you? And it may take a person a few minutes to wrap their heads around that question, but once you get the dialogue going, you can identify, is being home with your family the thing that's most important to you? Is living as long as possible the thing that's important to you? Is maintaining your independence the thing that is most important to you? And that can be used as a foundation to which you can guide all aspects of care. And finally, what do you think is causing X, Y, or Z? For example, if a person is suffering from intractable pain, ask them, what do they think that's causing that pain? I think you'll be surprised to find out that a lot of people don't necessarily ascribe physical disease processes to the cause of their symptoms, but things like a bad deed that they had done in the past or punishment from God. And in addition to the FICA tool that I mentioned on the previous slide, there are other tools that get to a lot of these issues, and they all have great acronyms like the FACT, the HOPE, the SPIRT. Another tool that I want to share with you in terms of spiritual assessment is something that I've adapted from the palliative care nursing literature, and it's really a great way to guide your assessment, and it can even be transcribed onto a written form if you're in the outpatient setting to hand to a person in their family. And it really offers some very non-judgmental questions to answer in terms of how they view their spirituality and what you as the healthcare team can do to help support their spirituality. So we ask, how important is spirituality or religion to you? How have your spirits been? And all they have to do is circle one of these: awful, low, okay, good, or great. And then there's a list of potential spiritual interventions that you can ask them to circle if they feel that that would be helpful to them. Pray with me. Allow time and space for private prayer or meditation. Bring or read inspiring things to me. Listen to my thoughts about spiritual matters, or provide assistance so I can record my life story, which is a very specialized intervention called life review that one often sees in the palliative care or hospice settings. Just be with me. Help me stay connected to my spiritual community. And if this was a real life form, you'd have a place for them to write their spiritual community or church group and who to contact there. And then if none of these are important to someone, they can say so. And you would also probably have a blank space where a person could write, is there anything else that you can think of that we could do to support you? So if we have identified existential or spiritual distress, or just an area in which we can intervene and provide additional support, what do we do? So a lot of this depends on one's own beliefs and comfort level. And again, that goes back to our initial self-spiritual assessment. One can never go wrong with listening. So I know that in our very busy practice, that seems like something we just don't have time to do. But certainly if you look at existential distress as a diagnosis, just like any other, sitting and listening can just be a very valuable intervention. And finally, expert consultation. I know I told you not just to check a box to see the chaplain, but certainly, I think anybody here would agree that our primary jobs are to help support and maintain one's physical health and well-being. And there are people out there whose expertise is solely based upon providing spiritual support. And in the hospital setting and in the hospice and palliative care world, extra certification is given to chaplains to deal with complex medical issues. So consulting a chaplain or your spiritual support team, which exists in almost every hospital, at least every hospital that I've ever seen. Talking to your licensed clinical social worker who may be able to intervene on his or her own or refer you to proper resources. If there is a palliative care team available to you either on the in or the outpatient basis, absolutely spiritual and existential distress is an indication to consult them, and most palliative care teams have access to a chaplain. And then finally, understand your community resources, particularly if there is a certain religious community or spiritual community that seems more prevalent in your practice than others. Always want to develop good relationships with them. And in terms of spiritual interventions, even though it's not directly on the slide, I do want to talk a little bit about praying with patients. As you saw, that was one of the potential interventions listed on our questionnaire on the previous slide. And if that is a venue in which you feel comfortable with and that coincides with your own spiritual beliefs, I would say it's absolutely appropriate for you to pray for your patients. I know that could be potentially a point of contention depending on your worldview, but from where I sit as a palliative care provider and a nurse practitioner for ages, that is an appropriate intervention. And not only does it help you develop trust with your patient and family, but it really gives you the opportunity to intervene sometimes in situations where you can't do anything medically to make the situation better. Lastly, I want to include a little talk about spiritual distress on the part of you as the clinician or the practitioner. And that's something that the literature may talk about with different labels. Compassion fatigue is something that you'll see very often. But as nurses, you already understand you walk with your patients and families through the most difficult and stressful times of their lives. And you often see horrific things as a bedside nurse that really take a toll on your own spiritual health. And as a nurse practitioner, this feeling and these situations are probably going to even become more intense because you have an increased responsibility as a nurse practitioner than even as a bedside nurse. So I want you, first of all, just to develop an awareness that this is a real thing and don't feel as though you are a failure or have let yourself or your patients down. If this type of compassion fatigue really starts to weigh on you. And after you develop awareness, you really might benefit from taking some steps to support yourself and intervene before you develop burnout or depression. So identifying a support system for yourself is very important. A lot of jobs come with great built-in support systems of your colleagues, but that might not be the same for everyone. So identify any type of resources your place of employment might have available to you, and sometimes you need to develop your own support system of either people who deal with similar situations frequently, or maybe what you want is a support system of people who have nothing to do with healthcare, so you can kind of look beyond all of the stressful things that we see every day. The process of formal debriefing can be very helpful, particularly after dealing with a difficult case or situation. And I'm not talking about an M&M where you revisit the case and try and figure out all the things that were done wrong or that you could do better from a medical perspective. But I'm talking about a forum in which you can just discuss your thoughts and feelings about a specific situation, or if somebody has died or suffered a bad outcome, where you can just really grieve for what occurred and what has been lost. And finally, self-care is so important, especially, for you guys right now. You're going to school, you're holding jobs, you're trying to take care of your family, and often you're putting yourself at the very bottom of your priority list. But in order to maintain your sanity and maintain your ability to appropriately care for your patients, you've got to take care of yourself. So take time, whether that is taking your full half-hour lunch break and getting away from the unit, or getting away from your charting, or making sure that you use all of your paid time off. Implementing things like exercise, and you can include here all other forms of wellness like proper nutrition and proper sleep, and I'm sure that the list is just endless. Formalized stress relief strategies such as meditation or yoga. Journaling can be very therapeutic for some of you. I've listed rituals, which can be very important, particularly if you are dealing in a field such as oncology and palliative care or hospice, in which you lose a lot of patients. And often it is very therapeutic to identify a ritual for honoring those that have died and really maintaining some kind of memory or observation of what has transpired. And finally, formal spiritual self-care, and that goes back to the A in our FICA. So if you have identified anything within your spiritual health in which you think you might benefit from changing, take a look at that. Maybe it is participating in your religious or spiritual support system more, or if you don't have such a system, maybe you want to explore that a little bit. So just really make sure that you're taking care of yourself spiritually, because if you're not doing that, you can't take care of anyone else. And I very much appreciate you listening to this lecture. I hope some of the concepts have resonated with you and you'll be able to take them forward into your personal life and your practice. And I'm going to leave you with this beautiful photograph that was taken in my inpatient palliative care practice. And I think this photo just about says it all. Thank you so much.